syndrome is real and has been puzzling the dental and medical professions for decades. This is the TMJ TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ TMD Demystified podcast.
Welcome, TMD Warriors. We're here for the next live stream on TMD Demystified. I'm Tony Urbanek. Today, we are going to talk about the difference between surgical and non-surgical treatment of TMD. To remind you, in the past couple live streams that I've done each Saturday, by the way, I encourage you to tell your friends about the live stream. If you are a patient who has TMD and looking for a solution or just looking for knowledge about this problem, or certainly if you are a doctor, especially a dentist, who sees these patients constantly and doesn't know what to do about them, TMD Demystified live stream every Saturday at noon is your opportunity to ask me questions and to be a viewer, and I'll be happy to respond to your questions, statements, or even criticisms. But today we're going to take a longer view on the issue of non-surgical versus surgical treatment of the temporomandibular joint. To remind the viewers who followed me along for the past couple episodes, 2 episodes ago, I showed my presentation to the National Academy of Sciences, Engineering, and Medicine in Washington, D.C. in 2018, in which I asked them politely, almost begged them to look at chronic inflammation within the temporomandibular joint as being the primary cause of all of the disparate symptoms, which is what my finding was, which is what my research showed, which is what my research proved in an independent study done by Middle Tennessee State University based on 3,000 separate temporomandibular joint cases treated by a device and protocol. Protocols are very important, that separates the posterior teeth, allowing the temporomandibular joint inflammation to decrease. That's all it does. And I showed that presentation 2 weeks ago, and last week I followed that by a presentation which ironically followed my presentation in Washington, D.C., in 2018, which was done by Dr. Gary Boulot, who is a chairman of the Department of Oral and Maxillofacial Surgery, or I think chairman of the training program, not chairman of the department, at Emory University in Atlanta, Georgia. And he represented at that meeting the American Association of Oral and Maxillofacial Surgeons and the American Association of Temporomandibular Joint Surgeons, that he stated that, and that's who he represented. And during that presentation, I stopped and showed how Dr. Boulot made a concerted effort to promote the use of total joint reconstruction for the treatment of temporomandibular joints. And he certainly had his point of view, and he stated very clearly throughout his presentation that he thought the science showed that a total joint reconstruction was an appropriate thing to do under certain circumstances. And I also am a member of the American Association of Oral and Maxillofacial Surgeons and have been for 50 years, and I did many total joint reconstructions. It's a very big operation. It's an operation that should never be done by someone who isn't really skilled at it and does it often. It has a lot of potential complications, a lot of serious potential complications if it isn't done correctly. I'm well aware of that. And there are occasionally needs for a total joint reconstruction, but they're very far and few between. For example, if you have total ankylosis, in other words, the bone has grown together, the joint has grown together where the patient has no function at all on that joint, would be a very good opportunity and a very good reason to do a total joint reconstruction. or what we call agenesis of the joint itself, agenesis of the total joint, which would be the joint itself is not there, and there are occasional cases of that. They're usually associated with genetic problems. And then there are a few genetic problems, major facial growth genetic problems that would have a need for a total joint reconstruction. So there are a few cases where it is really necessary and appropriate to do a total joint. But Dr. Below has a different point of view as to the general nature of a total joint and how often it would be used. It differs from mine. But I actually took the opportunity about 4 years ago to do my own presentation at the 100th episode of TMD Demystified, which was published on Dentaltown and now published on YouTube, to show that a temporomandibular joint that is majorly destroyed, that under most circumstances that any temporomandibular joint surgeon would look at that joint and say that joint needs a total joint reconstruction. I used the opportunity to take 17 of my worst cases that year. I do about 500 cases of non-surgical temporomandibular joint treatment per year now. And because of my experience and the success rate using a device that unloads the temporomandibular joint long enough to allow the inflammation to decrease to the point where all the symptoms decrease, you can avoid any kind of temporomandibular joint surgery, whether it be arthroplasty, arthrotomy, lysis and lavage, meniscus replacement, which is really not technically warranted in any cases, and certainly not total joint reconstruction. But I took the opportunity roughly 4 years ago to celebrate my 100th episode by showing 17 cases, 17 separate cases in my practice who had such severe temporomandibular joint damage that a TMJ surgeon would have easily decided that this would be a need for a temporomandibular joint total reconstruction. And so I want to show you portion of that presentation. It's a 30-minute presentation, and I won't make you sit through 30 minutes, but I want to show you the first 3 or 4 cases in that, which will describe and show you specifically the X-ray showing that the joint has significant joint damage that would, in other hands, would lead to a total joint reconstruction. What the patient's symptoms are when they arrived, and then they were treated non-surgically with a device that unloads the temporomandibular joint by simply separating the posterior teeth long enough according to a protocol. It has to be done according to a protocol, careful protocol, so you don't have problems with the bite or interruption of the occlusion. And what the symptoms were, and then after the X-ray and what the symptoms were, I showed what the patient's success story, their personal statement about their success and their statement about how that went, the non-surgical treatment, and that they were able to avoid surgery by doing a non-surgical treatment. So what I thought I'd do is I'd just share my screen and roll this for just a few minutes. I think I'm going to show about 14 minutes of it. And then I'll have some final comments about today's presentation. I'm watching my screen here to see if there are any viewers today have any questions as we roll through this. But if there are any questions, if there are any comments after this presentation on my 100th episode of TMD Demystified, celebrating the fact that we have solved the temporomandibular joint problem. This short 14-minute presentation will start out with a normal case, what normal joints look like, and then it'll go through a few cases of what very, very damaged cases look like, what the symptoms are, and the patients themselves, what they had to say about using non-surgery versus surgery, and especially total joint reconstruction, which they certainly would have avoided. So let's see if I can share my screen here, and we will begin, I believe.
TMD warriors, we are gathered here for the next episode of TMD Demystified, and I am Tony Urbanek. Today, as promised, I am going to do a little self-celebration and share it with you. I hope that you'll get something out of it. I think you will. I had to spend a little time figuring out what I wanted to do for the 100th episode of TMD Demystified on Dental Town. I had some options, but ultimately, although it took a little technical work to figure it out, that I put together a program on the computer which identifies a significant number of our patients who avoided surgery and had significant damage to the temporomandibular joints and actually avoided surgery. And we're going to document and talk about that a little bit today, because the backstory goes like this. If this is your first time listening to me, I need to get the backstory, but if you're one who watches these episodes routinely, you already know what I'm going to say. 12 years ago, I decided that after 30 years of doing temporomandibular joint procedures, surgeries on the temporomandibular joint, I decided to forego any further surgery, although we had some reasonably good results over a long period of time, and those are well documented. The results overall, I was not satisfied with, and I came into my office one morning and announced to my staff that we're calling off all further temporomandibular joint patients for surgery. But I had a long list of patients who wanted our services. I was well established as the temporomandibular joint surgeon in Nashville, Tennessee at the time. And I decided that I was going to see if I could figure out what no one else could figure out, because I knew there was no solution. Certainly surgery wasn't the solution. There were no non-surgical solutions. There were multiple procedures and things that were being done, the most common being the night guard, but everyone knows that is not effective. And then the story is, I won't take you through it again. It's like we went through the steps and actually figured out what everyone else had missed. Surprised me when I found out, with the help of my patients who gave me the key, what to do. I did that. It worked. I did 25 more. I did 50. Decided to see if we could put a patent on it, which took multiple years, actually 4 years, 2 more years to get the FDA clearance and approval. And now we're teaching this to other doctors who want to use the same tool and protocol to help their patients. But the point of today is, what I did is I selected out 17 patients from 2022 who had obvious significant damage to the temporomandibular joint, who in my hands or any other oral and maxillofacial surgeon who did temporomandibular joint surgery would have been a surgical case. And each one of these patients, I'm going to take you through a little history on them. I'm going to take you through a review of the x-ray, which is really what I want to see. I think this will be a teaching opportunity for viewers to actually see some really nasty temporomandibular joints. And then I'm going to read you their success stories. And some of these success stories are a little embarrassing, because I constantly tell patients, when I ask them to write a success story, I say, please don't brag on me. I don't need it. I don't want it. Just tell your story. Tell in your own words what happened when you went through using the device and protocol. And we're going to read some of those. We're going to read all of them on 17 cases. And I'll try to march through these as rapidly as I can, but not so rapidly as you don't pick up the meat of what I'm trying to show you, which is that significant damage to these joints, which with significant symptoms can be handled non-surgically, by unloading the joint according to the proper protocol, according to the proper method. So let's go ahead and just start. And we're going to start out with just a normal case. Again, 2022, we had over 500 cases that we did successfully. Literally, we have a problem in the office. We can't get people back once they think their symptoms are gone. So out of those 500 cases, really only about less than half of them went through the entire 6-month protocol, because once patients think that they're fixed, I'm fixed, I don't need to go back. And that is very, very common around here. But basically, we do about 500 cases a year. And 2022, we had 140 success stories. I always wait until the patient can, in their own words, and at the time, they can claim subjectively that they have at least 80 to 85% of their symptoms, whatever the symptoms are, the total number of symptoms, diminished, decreased, or gone. And that is the point where I ask them if they would care to write a success story and take a little picture. And we have 140 of those. And out of those 140, I picked out the worst of the worst X-rays. That's what the selection process was, not the success stories. The worst of the worst X-rays, which would obviously, in my hands or hands of other oral and maxillofacial surgeons, been a surgical case. But we're going to start out with a normal case. This is just an example of a normal X-ray. This patient was patient in 2022. And I just want to point out, you have a normal position of the condyles within the glenoid fossa. And the surface of the condyle is well positioned, and it is clearly smooth, and it's basically a X-ray, a Panorex of a normal patient. This young lady, I'll just read her success just to prove that this is a case that would not have been a surgical case in my practice, a surgical practice. But this young lady says, Dr. Urbanek is very knowledgeable. The Urbanek device has limited the majority of my symptoms in just a few months. It's no longer painful to eat breakfast in the morning. I do not wake up with headaches and facial swelling. All right, so let's move into case number one. What I'm going to point out is really a good example of bad-looking joints. This patient is 50 years old. Symptoms that this patient, Tracy, came in with were history of headaches, earaches, jaw pain, shoulder pain, jaw locking, and interincisal distance was 45 millimeters. She could open lower side of normal. But look at these joints. They are certainly not the worst. This is kind of a normal appearing bony surface of a joint, but you can see this, what we call chicken's beak right here. This indicates that a large portion of the superior surface of this condyle has resorbed. This part is gone, leaving this, what we call in the vernacular, the chicken's beak. Much worse over here, and you can see the modeling of the condylar head, and all of this is generated by inflammation within the joint. If that isn't understood or said, I'll make that clear. Inflammation within the temporomandibular joint literally causes all the damage to the meniscus, all the damage eventually to the modeling, degenerative change, degenerative joint disease within the joint itself, all generated by the inflammation, chronic inflammation. This patient's success story is pretty long, so I'm just going to briefly read it. I came in with multiple complaints to include neck pain, ear pain, jaw pain, popping. That was somewhat, and my jaw was somewhat malaligned with headaches. To sum things up, 80 to 85% of my complaints are relieved. Back sleeping is easy. Breathing is easy. Hip pain is gone because I wasn't sleeping. Couldn't sleep on my back. No more eating ibuprofen and Tylenol like candy. My bite is correct. Headaches and jaw pain, neck pain are relieved. Both doctors and all their staff are very helpful. So that's kind of the general nature of it. I won't go on and read the entire thing. Next case, a little bit different. Case number 2 is a 39-year-old female with her history of headaches, jaw pain, shoulder pain, arm, hand, finger tingling, and numbness and locking, with neck pain going back 20 years and interincisal distance, max interincisal distance of 33 millimeters. She could not open all the way. Definitely, obviously, a surgical case, most likely a total joint surgical case. Again, to point these things out, you can see the chicken's beak here. You can see how flattened the head is rather than round. You can actually, on this x-ray, I believe you can see a little bit of the meniscus, although cartilage does not show up well on x-ray. But the degenerative change on the surface right here on the right side, this being the right side of this joint. So again, case 2, surgical case. And this patient states, let me move myself out of the way here a little bit. I have suffered with pain in my left jaw for over 20 years now. I've had a couple of dentists make me a retainer because they said I would grind my teeth when I was sleeping. It barely helped at all. In 2022, the pain became so bad when I would open my jaw. When I open, the jaw would lock up, and it was so painful to open my mouth. Then I had pain run down my left shoulder into my hand. We can talk, I've talked before about how you get arm, hand, finger tingling and numbness. I would drop everything I touched. I went to the physical therapy and it barely helped. It was time consuming, costly. Finally, I went to the dentist and told him I could not deal with it anymore. He referred me to a TMJ. He made me a special device and it changed everything. I wear it when I sleep and the pain has been reduced dramatically. So that's what Lauren has to say, and Lauren missed the surgical experience. Next case, interesting case here. First, I just want to point out, and I don't want to get too off purpose here, but obviously this patient has a lot of missing teeth. I can tell you this patient did not use a mandibular partial denture, but had an upper partial denture before the x-ray was taken. But her sole occlusion was on these 2 first molars. This is Leslie, a 74-year-old male. In any case, look at these joints. We have flattening here. You're starting, this right here is a subcondylar cyst, which is caused by degeneration within the temporomandibular joint and degenerative joint disease. Look at the shape of this condyle as it's beginning to degenerate, bony loss. And Dan's success was I was referred by my dentist due to TMJ, and having followed Dr. Urbanek's recommendation. Dr. Urbanek is my associate. Treatment procedure, my pain level has all but disappeared. Bad joints would have been surgery before, would have been surgery for sure. Next case, right joint doesn't look too bad, but the left joint, look at this, total flattening. Most of the condyle is gone. You can imagine what that does to the bite, how it shifts the mandible over to the left when that occurs. Of course, over a period of time, the teeth will attempt to follow And that's a whole other issue of the orthodontic consequences of degenerative changes of the joint. But this is case number 4. It's Lindell, 60-year-old female. Original symptoms. Patient presents with headache, earache, jaw pain, neck pain, ringing, a subjective hearing loss, vertigo, shoulder and arm pain, arm, hand, finger tingling, and numbness with locking, and feeling that the teeth do not meet together properly. Just what I said, teeth do not meet together properly, and the headache going back 50 years. So we have a 60-year-old female who started having headaches when she was 10 years old, now has significant damage to this joint, obviously would have been a total joint replacement in other hands. And what does she say? She says, wow, what can I say except my TMJ device has lowered my daily pain levels to a point that I sleep great now. I have movement in my neck and shoulders that I hadn't had in years. Headaches are gone. I wouldn't take a nap or go to sleep for the night without it. Next case, this one is pretty profound. Look at the size of these condyles. Look at the lack of integrity of the surface of the condyle. Again, we're getting degeneration within the condyle, subchondral cyst right there. Very diminutive condyle. Takes years to get a condyle looking this degenerated. How many years? I mean, 20, 30. This case obviously has had pain for quite some time. The history of this patient, Wanda is a 75-year-old female and comes in with headaches, sinus headaches, mandibular pain, dizziness, and vertigo, headache going back 50 years with vertigo getting worse. Definitely, this would have been a total joint. In fact, probably both of these would have been total joint replacements, big operation, several days, at least a couple days in the hospital. Honestly, between the surgeon and the hospital and anesthesia fees, we're talking, depending on where you do it, on the east or west coast and middle of the country, between $60,000 and $110,000 to do this kind of surgery, all told. Somebody pays that. You pay it with your premiums. Your employer pays it. Wanda says, I have had headaches and facial pain most of my life. My dentist asked me to see Dr. Urbanek for the jaw catching and hurting. He knew exactly what the problem and solution was and is. He is correct in his assessment of solution. I'm very pleased with the result. The popping from my jaw is rare and pain is gone. Very nice lady. I remember her really well. There's not much I can say. And believe me, I feel a little embarrassed sometimes reading these things. But I want you to celebrate along with me that what we've discovered here, what we use, is huge in the realm of treating temporomandibular joints successfully. It was what my vision was back 12 years ago, is trying to figure out what was really happening here.
All right. All right. So I hope that came through. I hope that recorded. I think I had a few extra things on the screen that didn't need to be there, but I'm not a computer engineer. I hope that came through, and I hope it was meaningful. It speaks for itself. My position on this issue is that the surgeons don't need to be doing surgery, especially total joint reconstruction. I compared and contrasted honestly in the 2 prior episodes of the live stream that what I presented to the the National Association of Science and Engineering Medicine, helping them or directing them to look at my research, which was independent research provided by Middle Tennessee State University. I sent them 3,000 patients to query and and create the research project. I had no part in actually designing the research, asking the questions. I sent the 3,000 patients for them to take a look at and come up with their own conclusions. It was under the monitoring and auspices of a independent review board, an IRB, and the statistical study. This is a statistical study that showed patient success or patient approval, patient happiness with the device and protocol at 85%. And that survey did not include people who didn't do the protocol correctly, who didn't use it the way they ideally should use it. So there was some patients included in that study who didn't follow the protocol correctly, and therefore what we see in our clinic actually is a little higher than 85%. It goes into the 90s, goes in 95% of people who follow the protocol will get the response of their symptoms diminished or gone and not have to go through surgery. And then I showed Dr. Boulot's presentation where he specifically represented the American Association of Oral and Maxillofacial Surgery, and he specifically represented the American Association of Temporomandibular Joint Surgeons, and tried to persuade the group in Washington, D.C. that total joint reconstruction was appropriate. Now, as I did on my last live stream, I also want to show the position paper that was created by the American Association of Oral and Maxillofacial Surgeons as to exactly the position of AMUS, American Association of Oral and Maxillofacial Surgeons, as to the contemporary management of temporomandibular joint intra-articular pain and dysfunction, TMD problems. And as it works out, Dr. Boulot is the head author of this position paper presented by the entire organization. And within this paper, as I stated last time, that the position of the AMUS is that much more conservative things need to be done before surgery is considered. And I will read this paragraph again. The paragraph is entitled, "Initiate the least invasive evidence-based non-surgical or the least invasive evidence-based non-surgical or surgical treatment." So you want to use the simplest and the least invasive treatment before you do the most invasive treatment. And I'll read the paragraph. "Non-surgical treatment for the management of temporomandibular joint problems may include rest, heat, ice, non-steroidal anti-inflammatory drugs, muscle relaxants, physical therapy, and orthotics." This, ladies and gentlemen, is a orthotic. It's a very simple orthotic. It is the device that separates the back teeth that allows the inflammation to go down if used correctly, following the correct protocol. You do have to have some training. You have to know how to use it. But if you follow the protocol, you will get the results specified in this statistical study, independent statistical study on an FDA-cleared device. And so I want to bring out to your attention, if you hadn't seen it already, the conflict between the notation and statements by Dr. Boulot before the National Academy of Science, Engineering, and Medicine and his actual position paper, which was approved by the whole association. And then finally, I'll just repeat my statement that in my attempt to bring this information before the American Association of Oral and Maxillofacial Surgeons to present this study, it is the scientific way to do it. You would, as a member of the American Association of Oral and Maxillofacial Surgeons, I have the absolute right to apply for and present to my group my specialty group, fellow oral and maxillofacial surgeons, knowledge that I have that I know that might be helpful. And I attempted to do that, to bring this study to their attention 3 separate occasions. After it was denied the second time, I queried and actually complained to the American Association, to the right individual, and was told, well, just do a short presentation, just do an abstract, do a 5-minute abstract, giving the basics of your information to the group at a national meeting, and then you'll have your foot in the door, and then you carry on from there. So I did. I applied for a 5-minute abstract and was denied, to bring to the attention of my own group, oral and maxillofacial surgeons, this study. So I will let the person viewing or listening to this live stream decide for himself why that might have occurred. I will let you make your own determination. I think I have my own opinions, but I won't even voice them. So I've been watching the clock. It's been 35 minutes since we began here. At this point, I have no further questions. I have no comments to bring to your attention on the live stream. So I'll pretty much end it there. I look forward to carrying on this. I have more to say and more to show about and much more to show about this meeting 7 years ago in Washington, D.C. on March 13th, 2018. There were many other presenters that presenting the position, their concern, their symptoms, and what those symptoms meant to them, and how this disease devastates their life. It's a serious, serious disease. And I think there'll be a further series of presentations by other people at that meeting to bring to your attention in 2026 exactly what was going on at that meeting in Washington, D.C., and comparing and contrast it to present time. And I think there's a lot to compare and contrast. With that said, I'll end it there. I'll invite anyone who would like to comment directly to me or contact me. I'm available at my email address, tony@tmjservices.net. If there are any dentists out there, and I know both public, patients with TMD, and dentists who would like to treat TMD or know more about it, watch these episodes. And if any dentists or doctors who would like to treat TMD appropriately non-surgically with a device and protocol that actually works substantially well, that information can be gotten at www.urbaniktmj.com, URBANEK, TMJ.com. With that said, I look forward to the next time. I hope you'll return to get more information. I am Tony Urbanek, and this is TMD Demystified.